Hello, I'm Praveen Goday, Associate Professor of Pediatric Gastroenterology and Nutrition at the Medical College of Wisconsin. I will be talking to you about quality improvement in failure to thrive management. We have no faculty disclosures. Today, my objectives will be to define failure to thrive, discuss its prevalence, talk about some normal variants which masquerade as failure to thrive, provide an approach to the assessment and management of failure to thrive, and to briefly discuss its prognosis. Definitions. Whenever a condition has more than one definition, it suggests that there could potentially be a problem, and this is the case with failure to thrive. There are at least 7 definitions in the literature, and this leads to confusion. The 3 that I will discuss here on forward are weight for age, less than the 5th or the 3rd percentile. The other definition involves weight deceleration across 2 major percentiles. And finally, the 7th definition refers to conditional weight gain, and it is important to note that there are no specific US charts that chart this. There are WHO growth charts that give us conditional weight gain, but they are not easy to use. So on to the weight for age less than the 5th or the 3rd percentile. This is not difficult to understand, but is this a good use of a definition for failure to thrive? Firstly, is 3% of the population below the 3rd percentile? If we look at the WHO growth charts, they took out the outliers with regard to the thinnest and the most overweight of children. So they took out children who were greater than or less than 3 standard deviations above the sample median. So the most important outliers are all already excluded, and for these charts, 3% of the population does not fall below the 3rd percentile. Secondly, is weight alone enough? Often, proportionately small children are not failing to thrive. So weight for length or body mass index, depending upon the age of the child, may be a better way of defining failure to thrive. This slide is a reminder that you should turn the page over and look at the weight for length or the BMI, understanding that many of you are using electronic medical records. You still will have to electronically turn the page over and look for either weight for length or BMI to properly define a child as having failure to thrive. Weight crossing 2 major percentile lines, these tend to differ between the CDC chart and the WHO growth chart, but that is not important. The question is this a definitive, does this confer a definitive diagnosis of failure to thrive? It is important to remember that stable growth during infancy also includes traversing through growth lines. 6 to almost 40% of children will traverse through weight lines between birth and the age of 2 years. Also, one other study correlated weight at 1 year with weight at 4 to 8 weeks rather than at birth, and so that may be more important. The other thing to remember is that growth curves are actually mathematically smoothed out and they are averages, so this itself may cause children to move up and down growth lines slightly. Which growth chart should we use and for what ages? The CDC recommendations, which were also endorsed by the American Academy of Pediatrics, tells us to use the WHO growth standards up until the age of 2. The CDC growth chart should be used for all children above the age of 2. It is important to use the WHO growth standard irrespective of the type of feeding. Whether the child is breastfed or bottle fed, if the child is less than 2, the child should be put on the WHO growth chart. When using the WHO growth chart, the 2.3rd percentile and the 97.7th percentile, which are labeled as the 2nd and 98th percentiles, should be used as indicators of abnormal growth. The CDC growth chart should be used for all children above the age of 2. Moving on to prevalence, we should look at a Danish birth cohort where they found that 3% of children under the age of 1 were significantly malnourished. Now, going back to those 7 definitions that I put up on an earlier slide, there was very poor concurrence among all 7 criteria. None of the children with failure to thrive met all 7 criteria. Most only met 1. But if each single criterion was taken into account, it either identified too few children or identified too large a proportion of the cohort. We now will talk about normal variants masquerading as failure to thrive. Genetic short stature is an important cause of short stature and therefore of failure to thrive. Short parents obviously produced short children. These children have lower percentiles but tend not to cross percentiles. In order to get an estimate of where the child should grow, we do use the mid-parental height. There are several formulae available for calculating mid-parental height. This is one of the easier ones. To each child's, parents first obtain the average of the parents' heights, then add 2.5 inches if it is a boy and subtract 2.5 inches if it is a girl. This is the median height or the 50th percentile for where the child should grow. We then need to look at 2 standard deviations both above and below this number, and that is provided by adding and subtracting 8.5 centimeters. I will give you an example on the next slide. Looking at this example, mom's height is 5 feet 5 inches, dad's height is 5 feet 8 inches. If you look at their average, it's 5 feet 6.5 inches. And to this, if you add 2.5 inches, you get 5 feet 9 inches. And this now gives us the median target height. To this, you can then add and subtract 8.5 centimeters, and this gives you the 2 standard deviations on either side. Now, this boy should grow at least to between the 5th and the 10th percentile in height. Now, looking at him, he is presented to your office with failure to thrive, and looking at his height, he clearly will not meet his target height, and therefore his height is of concern. Other normal variants include prematurity. This is the kind of child who has a normal birth weight when corrected for gestation. These children, as they continue to grow, especially during the first 2 years, have low percentiles if uncorrected, but may show catch-up growth. With the new switch to the WHO growth charts over the first 2 years, it may be appropriate to just correct all parameters up until the age of 2 years. It becomes more difficult to provide corrected anthropometric measurements beyond the age of 2 on the CDC growth chart. This is an example of correction for prematurity, and this can usually be done by your electronic medical record as well. Constitutional delay is an important masquerader of failure to thrive. Children may have an initial drop in percentiles and then follow their own curves. Typically, a family history is positive. In a girl, a mom may have a delayed menarche, while in a boy, dad may have continued to grow late in high school and beyond, and this can be confirmed by a bone age assessment if so desired. Catch-down growth is not often talked about. This is important in children who have above expected birth weights. They tend to have an initial fall in percentiles and then they follow their own percentile. This is important in large for gestational age babies. So what would a good practical definition of failure to thrive be? The first thing is looking at the weight for length, which is less than the 2nd percentile on the WHO growth chart, or a BMI less than the 3rd percentile for children above the age of 2. Poor or no weight gain over a period of time, that is going to vary depending on the age of the child. In a very young child, the duration of time between visits will be should be short and can still be concerning. For instance, if a month-old baby has not gained any weight in a week, that's going to be concerning, but this is not going to be concerning in a 5-year-old. Significant downtrend in weight percentiles can be of concern, but you need to remember that normal children too will cross percentiles. Finally, all of this should be done along with correction for parental size as well as parental growth, and finally correction for prematurity if such a correction needs to be made. Do all children with failure to thrive have medical risk factors? It is important to remember that 95% of children with failure to thrive or even more have no organic disease at all. Less than 5% will have organic disease. Does this mean that the vast majority of children with failure to thrive are neglected? No, it does not mean that, because only 5 to 10% of failure to thrive infants are followed by child protection services. Now I will start with an approach to further analyzing failure to thrive and its management. A simple approach to a failure to thrive is, firstly and most importantly, 90% of children or more actually have an inadequate intake of calories. Loss of calories tends to be the other most important problem. This is usually manifested by vomiting and diarrhea, diarrhea being a surrogate for maldigestion and malabsorption. Occasionally, there is increased caloric need. This is in children with overt cardiorespiratory disease, chronic renal or hepatic disease, and children with chronic infections. Finally, some children have an inability to utilize the calories that they are consuming. This tends to happen in children with chromosomal disorders who are not able to grow like normal children, or in endocrine or metabolic disorders. As I mentioned before, failure of food intake underlies most cases of failure to thrive, whether this is due to an actual lack of food or a variety of other beliefs needs to be ascertained, and can also be due to specific organic issues in the child. Inadequate food intake can usually be figured out by a few simple questions. Where and when does the child eat? Who feeds the child? Are there distractions being used to feed the child? Is there any force feeding, or does the child graze on food all day long? This is what we do with most of our patients when we see them. We get a history and a physical examination and consider laboratory studies. And failure to thrive is no different. In failure to thrive, the history starts at the very beginning. It is important to get a sense of birth weight in an attempt to define small for gestational age as well as large for gestational age. Early neonatal history is also important, as are feeding issues in the first year of life. In general, early feeding issues may be a harbinger of neurological or other developmental problems later on in life. The reason small for gestational age is so important is outlined in this slide. The most common definition of small for gestational age is 2 standard deviations below the mean. 90% of small for gestational age children will actually exhibit catch-up growth, and the other 10% will be diagnosed with failure to thrive. It is important to note that appropriate weight gain, which is not too much or not too little, is the best for the best neurological outcomes. Kids that do not catch up in weight do not have good neurological outcomes, but kids that gain too much weight tend to have poorer neurological outcomes as well as poorer metabolic outcomes, such as metabolic syndrome. This is a chart that you can use to figure out if a particular child is small for gestational age. This gives you the 2 standard deviations below the mean for each of these gestational ages, and is from the Olson growth charts, which were described a few years ago. Moving further on with the history, it is important to get a sense of development, medical and surgical history, as well as a history of frequent infections. This is probably the most important thing in the diagnosis of failure to thrive. It is to plot previous growth points and put them on a growth chart and compare them to the present state. Feeding behavior and environment, I had already provided you with some of the questions that you need to ask. We also need to know about allergies to foods, because some foods may be being avoided. and then we need to get a sense of how much the child is taking in. A qualitative versus a quantitative assessment may be necessary. In most instances, a qualitative assessment is appropriate. If you get a sense of what has happened over the past day or days, that should be good enough. In difficult cases, a 24-hour food recall or a 3-day diet diary may need to be looked at. Again, a social history tends to be very, very important. Apart from other questions, you also need to get a sense of the perception of the family with regard to growth failure, because if they do not see it as a problem, they are much less likely to intervene. With regard to the physical examination, there are 2 parts to it. The first is anthropometric measurements. These are vital for the accurate assessment of growth. And if you do obtain length, it is important that your office obtain length on a length board up until the age of 2, and thereafter use a standing height with a stadiometer. With regard to weight, in children less than 24 months, the child should be either nude or measured in a diaper, while children above the age of 24 months should be measured in light clothing with shoes removed and outerwear removed. And then a thorough physical examination should be performed. This will serve as an introduction to Z-scores. Looking at this child clearly was failing farther and farther away from the chart, falling farther and farther away from the chart as age went along. It is difficult to describe this in any quantitative terms once a child is below the first percentile, because less than the first percentile no longer has any meaning with regard to description of this child's growth. Hence the use of Z-scores. So a Z-score is the observed data point minus the mean divided by the standard deviation. It is also known as a standard deviation score. An example is given on the next slide. The top point has a z-score of negative 2.1, while the lower point has a negative z-score of 3.5. This clearly tells you where this child is with regard to the growth chart. These can now be plotted through various electronic medical records. The other way to plot them in children under the age of 2 are through the WHO Anthro program, which is available for free and can be searched and found through Google. The other option is to obtain the STAT growth charts, which is available for tablets and a variety of cellular phone devices, which can then plot these z-scores for you. It is difficult to do these out by hand. If we all began to use z-scores, we could eliminate the use of ideal body weight, which is fraught with a set of problems. We could potentially stop measuring weight gain in grams per day. We could more accurately describe our patients when they do not fall within the growth chart percentiles, and we could also use these data for statistical analysis. Now, moving on to short stature. Short stature is frequently confused with failure to thrive. Failure to thrive can also lead to short stature, but looking at this, about 35% of short stature is either constitutional or nutritional. The vast majority of short stature is due to genetic causes. Chronic illness such as inflammatory bowel disease and celiac disease constitute a small proportion, and the smallest proportion are endocrine disorders. It is also important to note that children with growth hormone deficiency are not usually malnourished, and also having a low serum IGF-1 does not immediately lead to growth hormone deficiency as a diagnosis, since in malnutrition, IGF-1 will be low. Again, looking at these patients who have low height, if they have both low weight and low height, malnutrition is possible. Children with typical endocrine problems tend to have a normal height, a normal weight, but a low height, while children with either endocrine or genetic problems may have normal weight, low height, and dysmorphism. Small for gestational age patients who usually show catch up within the first 2 or 3 years. If by the age of 3 they have not shown catch up with regard to height, they may be candidates for growth hormone treatment. What about laboratory studies? The importance of a thorough history and physical examination was established over 3 decades ago. In these studies, they showed that lab studies do not really help in the evaluation of failure to thrive. In 185 patients who were admitted to the hospital with failure to thrive, only 1.4% had labs that helped make the diagnosis. And of these, all of them were actually clinically suspected already. Therefore, most children with failure to thrive do not need labs. You may consider labs in children with severe failure to thrive or failure to thrive not due to inadequate calorie intake. Common labs that one would obtain are a CBC, a complete blood count, as well as an ESR, metabolic profile, a celiac panel, which is typically an anti-tissue transglutaminase IgA, as well as a serum IgA level, as well as a fecal elastase, and a urine analysis. Again, let's go back to assessment of dietary intake. Have parents describe a typical day and look for common red flags. The common red flags are excessive juice intake, excessive milk intake, and grazing. By grazing, I mean a child that is walking around either with a bottle or free access to snacks and other food throughout the day. This does not allow the child to get hungry during real meal times, and therefore the child does not eat well at meals and ends up failing to thrive. Here is our rationale for nutrition management of failure to thrive. Firstly, juice. Juice has 15 calories per ounce and no protein. It has clearly been shown to be a contributing factor in failure to thrive. Kids do not need juice. It is better to encourage whole fruits versus juice. The AAP recommendations are outlined on this slide, but in any child that is not growing well, the amount of fruit juice that should be consumed should probably be 0. Excessive milk consumption can cause iron deficiency anemia and constipation. Occasionally it can lead to failure to thrive as well because the kid is not taking enough solid food. In general, kids that are not growing well should get whole milk up until the age of 2. The recommended milk intake is 16 to 20 ounces up until the age of about 4 and 24 to 30 ounces beyond that period of time. When we talk about high-calorie beverages, we can add formula powder to breast milk to make it more concentrated. We can also increase the calories in formula by adding more powder to sort of under-dilute the formula. A variety of 30 calorie per ounce beverages are available for children above the age of 1. I have provided a couple of ready-to-feed examples there. The slightly cheaper version of that is to use a powder which is then added to whole milk. This can be accomplished by using Carnation Instant Breakfast. The final approach is to use whole milk, 7 ounces of whole milk with 1 ounce of heavy cream. It will still give you the 30 calorie per ounce beverage, but not necessarily with all the vitamins and minerals that you may want to add. When you suggest high-calorie foods, use the family's usual foods. Add fat only to the child's foods and suggest that fats that are added to the child's foods are appropriate to the food being served. For instance, it may be more appropriate to add some cream to strawberries than olive oil, and so on. Do not commence junk food. This should be stressed to every family. Mealtime behaviors. All meals and snacks should be at the table or in the high chair. It is pertinent to note that the family should be asked where the child eats. Some families are so poor that they cannot afford a high chair and the child just eats in a corner on a plate or on some newspaper. This can still be the child's place to eat, and everything can be done in that location even if a high chair is not available. The child should be fed every 3 hourly and not more than 20 to 30 minutes to eat and drink, and the child should only get water between meals and snacks. Should children with failure to thrive be given a multivitamin, multimineral preparation? 9% of children and adolescents in the US are vitamin D deficient, and separately a meta-analysis of zinc supplementation in children found positive increments in weight and height. Growth response was higher in children with low initial weight for age Z-scores. In addition, 8% of US children are iron deficient. This suggests that children with failure to thrive may benefit from a multivitamin, multimineral supplementation unless you have given them a high-calorie beverage that includes many of these multivitamins and minerals. It is crucial to note that not all multivitamin supplements are created equal. Use a complete pediatric multivitamin that can be crushed. Use a tablet. Do not use a gummy. The gummies don't tend to have all of the things that you need in them. Use half a tablet for 2 to 3 year olds, which can be crushed and added to food, while 4+ year olds can use a full tablet. Moving on to management. First, ensure that the child is failing to thrive using the practical definition that was suggested before. Work out the primary cause why the child is failing to thrive. It often will be inadequate calories. However, some of the time it may be loss of calories due to vomiting, diarrhea, or malabsorption. Occasionally, it is due to increased caloric needs, and then the other conditions such as chromosomal, endocrine, or metabolic disorders. Repeating the initial interventions for a child with failure to thrive. The child should be offered meals and snacks every 3 hourly. All meals and snacks should be offered in a set place. Distraction should be minimized. No TV, playing games while the child is eating. Avoid force feeding. Grazing in between meal and snack time should be completely eliminated. Again, high-calorie diet using the principles outlined before. Do not switch the child over to junk food. High-calorie beverages are the mainstay of taking care of children with failure to thrive who are very young, within the first 6 to 8 months of life. Here, the changes to their beverages are the first thing that's done. With older children, this is somewhat later, after making changes to the meal and snack plan, as well as adding calories to their food. Curtail sweetened beverages and other low-calorie foods. Occasionally, you will see a family that's overly healthy and feeds their child only salads. This family should be taught what appropriate feeding for young children is. Eliminate juice and sweetened beverages and encourage appropriate milk intake for age. In children with inadequate calories, these are the initial steps. They are outlined here before. I've just gone through them. The next steps are to increase calorie content of formula. Again, if the child is very young, this is the first step to be considered, and then increase calorie values of all foods. High-calorie beverages, especially in children over the age of 1, do not need to be given to every child with failure to thrive. It should be considered in children with moderate to severe failure to thrive and or unmotivated families where there is a risk of the child worsening if something is not done. There should also be a balance between these high-calorie beverages and solid food. The high-calorie beverage should only provide 50 to 70% of the child's calorie needs. And finally, wean off the high-calorie beverage at the very first possible opportunity. When there is a loss of calories, investigate and appropriately treat the causes of vomiting and diarrhea. Investigate for malabsorption if the child is consuming sufficient calories. And finally, consider referral to an appropriate subspecialist. Even in children with increased calorie needs, it is important to eliminate juice and grazing. you need to maximally concentrate all solids and liquids so that they're able to consume maximal calories in the smallest volume. Consider tube feeding early and referral to the appropriate subspecialist. Finally, a word about prognosis. A meta-analysis involving failure to thrive children less than 2 years of age showed a 3-point reduction in IQ in children at age 3. There are two ways to look at it. 3-point IQ reduction does not seem to be very much, but you have to remember that the decrement in babies whose moms have consumed cocaine while pregnant is much smaller than this, and the additive improvement of a child being breastfed in IQ points is also smaller than this number, so this may actually be significant. Another meta-analysis, which looked at less exacting inclusion criteria, showed that FTT is associated with adverse intellectual outcomes that are sufficient to be important, while a third study did not show any evidence of emotional deficit in teens who had had FTT before. Moving on to the critical documentation that is necessary. The first is to document whether the child does have FTT. So we would require you to obtain anthropometric measurements accurately and plot on the appropriate growth chart, obtain z-scores as and when appropriate. A large for gestational age, a small for gestational age status needs to be documented as needed. If premature correction needs to be performed, poor weight gain over time demonstrated, mid-parental height calculated, and parental growth documented as well. If the child does have failure to thrive, we need to figure out the calorie category where this child falls into, either inadequate calorie intake, which would be the most common, loss of calories, increased calorie need, inability to utilize the calories consumed. Next, documentation of feeding patterns. Does the child sit in a specific place for meals? Do the parents or caregivers use distractions to get a child to eat? Is there force feeding? Are there allergies to food? And finally, either a qualitative or a quantitative assessment of intake. This will most often be a qualitative assessment. Next, looking at other organic disease in the child, cardiac, respiratory, genetic, neurologic, chronic infections or others, gastrointestinal symptoms such as vomiting, diarrhea, feeding difficulties or abdominal pain. Moving on to the interventions that you are recommending, the appropriate amount of milk, high calorie formula or supplement, increased calories in solid food, sitting child in a specific place for meals, avoiding distractions, cutting out grazing and juice, avoiding force feeding, and whether or not a multivitamin has been prescribed, checking off the time that you're going to follow up with the child. The follow-up will be based upon how severe the child's FTT is and how young the child is. In general, younger children will be seen more quickly, and finally, whether there is referral to a subspecialist. The way you will end up improving quality is by identification of benchmarks and standards. There will be additional training and education. The self-evaluation and reporting will ultimately lead to quality improvement. The next steps are the MOC activity focused on FTT, repeated reporting of clinical performance in cases of FTT, and completing the case report form on 10 patient cases during each of 3 reporting sessions, receiving clinical performance reports after each session, and engaging in the quality improvement process to improve performance. The format will be PowerPoint slide presentations with accompanying video, reference lists, and clinical resources. In summary, making a diagnosis of FTT requires a combination of objective and subjective information. Once a diagnosis of FTT is made, further information is required to guide management. Most children with FTT do not require laboratory studies, and most children with FTT can be managed through a series of simple interventions to increase calorie intake. Thank you.